we're going to talk about functional occlusion. Let me go back to this. The title of the lecture is Function and Aesthetics. It's a predictable marriage for success. And I know a lot of you out there are very good at doing great aesthetics. And I've done so much teaching, and I've traveled, and I've heard the same concerns wherever I go. And we don't understand occlusion. We love to do aesthetics, but the missing piece of the element is the functional part. And I want you to all remember that when your patients come to you, they are going to be aesthetically driven, which is wonderful. However, you need to be functionally driven as a clinician. In other words, solve the aesthetics, but keep the function in mind, because that will allow the aesthetics to last longer. However, if a patient is functionally driven, I don't think it's appropriate to kind of push them to the aesthetics. However, if you think by changing the anterior teeth can improve the function, well, then I want you to make those anterior teeth look the best they possibly can, which is more to do with aesthetics. So our challenges in our practice is to educate our patients both on function and aesthetics, and depending on what their needs are, we have to create a marriage of these two elements because they go hand in hand. So as we go through this process, I want to spend some time to talk about the fundamentals of occlusion. I want to talk about functional occlusion, and I want to talk about functional aesthetics. I'm going to try to talk about all of these elements while I'm discussing a case with you in detail, and that way we can do this. But I want you to all look at this picture and just pretend this patient walked into your practice and said, I've got 2 broken anterior teeth, and I would like them restored. Just by looking at this photograph, I think most of you would think we could just add some composite, or we could do some very conservative veneer restorations, and we would be done. Perhaps even some whitening, as far as the aesthetics are concerned. And so if I were to show you something else of the same patient, this patient, when they go into extreme excursive movements, that lower canine lands exactly where the incisal edge is on that broken tooth. And so imagine now, if you were to do this same patient, if you were to go back and restore this in composite, how long do you think that restoration would last? If it was done in porcelain, it may last longer, but based on this behavior, this functional behavior, that restoration will fail. I can guarantee that it would fail, and I think you all can see that. And so we need to be aware of what our patients are doing when it comes to function, so that we can protect ourselves in the sense that we can provide predictable treatment. And if there's an issue like this, well, then there's something wrong with function, and we need to modify this person's occlusion to avoid this type of movement. And so now you can certainly see there's functional concerns. And if we look to a different patient who presents something like this, for example, and if we were to take another photograph and retract and look at what has happened to the wear on this particular patient, I'm sure most of you see people like this in your practice all the time. My question for you all is, if you are seeing them, what are you doing about all of these signs of instability? Are you talking to them correctly? Are you educating them in the way that makes sense? But when we look at this, we can see that this tooth right here, tooth number 9 or 2-1, has a wear pattern that is very different than the wear pattern that you see here. And the reason why it's different is because this tooth is slightly rotated. And when we have a rotated tooth like this, we can expect and will see different patterns of wear. And so if we get closer look at the lower anterior teeth, here is the view from the facial. But once you look at it from the occlusal view, you can see that we don't have an ideal arch form. We have the 2 centrals more protruded. We have slight rotations here, and all of these teeth are wearing down. However, what our patients don't know is that they don't realize that their teeth are wearing down. And there's a reason why they don't realize it, is because teeth migrate when they wear down. And so here's a great example of the same patient. If we look a little closer, we understand the signs of instability are existing, but I want you to look at the soft tissue. I want you to look at where the wear patterns are, and I want you to draw an imaginary line between the canines of the lower anterior teeth. And that might give you an indication as to how much wear has occurred. But more importantly, let's look at the gingival margins. You can clearly see that as teeth wear, there is eruption. And as the tooth erupts passively, the entire dental-alveolar complex moves with it. And so when you're looking at patients like this, take pictures where you can actually see the evidence. Because sometimes when patients don't realize they're grinding, this is a great indication as to show them as to how much they've lost over the years. So I'll leave you with this, and I think that's a great an example of what we can do to educate our patients. So when it comes to aesthetics and function, it really doesn't matter if your patient is just seeking two restorations. The case that you're seeing here, we restored the two central incisors with some whitening. We did very conservative veneer preparations. Or if it's a patient who's functionally driven, who has certainly more signs of instability, but we restored them in composite. It doesn't matter. What matters is, do you understand function and occlusion and aesthetics? That's what matters the most. And the point I'm sharing with you is, it doesn't matter how complex the case may be, the principles of how we treat these patients are exactly the same. And so we're going to go through some topics before we get to the case, but I'd like to ask you this question: where, in your opinion, does aesthetics begin and end? We won't spend a lot of time discussing this because that is very subjective, but what is not subjective is this question: where does function begin and end? And I'd like to share kind of what Pete Dawson has shared with us for decades, and that function or occlusion starts with a stable joint position. And I think that's the fundamental difference between what we're teaching and what other schools of thought are, is that we want to provide a stable joint position and then build the occlusion. But if you think about occlusion, if it starts at the joint, then it must end in the anterior teeth, because the anterior teeth provide the coupling. The anterior teeth provide the disclusion that's required for a stable occlusion. And so when we're designing aesthetics, we need to make sure that we are contouring and designing these teeth appropriately to complement the patient's occlusion. So what does functional design mean? Well, let's look at this in more detail. If we were to look at the aesthetics, you can see that we focus primarily on the facial incisal components of the front tooth. And then if we look at function, we can all agree that that would be the lingual incline of that same tooth. We tend to focus too much on the aesthetics and very little on the function. And this, what Pete has designed, is called a functional matrix. It's the functional design of how we design teeth. And you would think that we would start the design by looking at the facial side first, but we start the design by looking at a centric stop on the lingual surface. And then we go to the incisal edge position. And then we decide the facial lingual contours. And then we look at the cingulum. And then we decide for phonetics. And we decide all of those things while our design is being made in the provisionals. But the question for you all is, how do we design for both? And that's really why I wanted to spend some time with you all tonight and discuss that. So I want to remind you all about some of the requirements that Pete taught us, and is that we want equal intensity context while the joints are in centric relation. We want to make sure that those teeth can disclude all the posterior teeth in protrusive movements. We want to make sure that the front teeth can disclude the non-working side and the working side. And we want to make sure we have anterior guidance in harmony with the envelopal function. I won't spend a lot of time on the topic of envelopal function because we can spend 2 or 3 hours on this, but those are the 5 basic requirements that we need to always remember. I think in realistic terms, that's what a perfected occlusion looks like on a textbook. We can put dots where we believe where they belong. But in the real world, this is what it looks like. And you can get the dots as close as you can. But my advice to you all is that when you're trying to dial in someone's occlusion, try to make the landing places in a predictable flat area, cusp to fossa, and that's the goal. And then when we talk about function, we want to have guidance. We want protrusive guidance. We want to make sure that all of our posterior teeth are discluding. We want to have canine guidance as well. And it looks something like this in the real world. You can see that we've got nice canine guidance. We don't have any red lines in the back. We only have red lines in the front. And this lingual contour is designed in a way that it's very easy for that patient to disclude the back teeth. When you're equilibrating your patients, pay attention to how difficult it is for that patient to go into those excursive movements. If they're struggling, for example, if it takes a little bit more effort to get the canines to disclude the back teeth, perhaps these inclines are too steep, and maybe that patient isn't comfortable going up that steep slope, and maybe you need to shallow that guidance a little bit more so it's a little more smoother for that patient. And the same thing applies for the lingual components of the anterior teeth. If it's too steep, you might trap your patient. If it's nicely contoured with the envelope of function, that guidance is very smooth and effortless. And I think that's a great pearl that I've learned over the years, is to pay attention to what is happening with the patient and ask them, how does this feel? Is it comfortable? Is it difficult? Is it getting smoother? Is it getting more comfortable sliding into these different positions? I want to review the mascatory system with you all, because this is what Pete has preached to us so profoundly. And I want to kind of simplify this for you. You've got teeth, muscles, and the joints. There is communication between all of these components to the brain, but there's also communication between all of these components as well. And I'll give you a great example of how it's important to understand this. If you've eaten something and you found a small fragment of bone or a particle of something that doesn't belong in that bolus of food, this mascatory system that you see in front of you can have immense communication skills to dissect that small piece out of the bolus of food, even as small as a hair. And so we have to respect the system. We must always understand that the system is extremely sensitive to the smallest thing, like a piece of hair. So when you're designing occlusion, if it's off by even a little bit, the mascatory system will try to adapt to the best it can. And sometimes during that adaptive phases, things start to fail. And so the only way that we can understand the mascatory system is to do a thorough comprehensive examination. I'll briefly go through joint position very quickly. This is a view of the eminence. You can see that's where the medial pole is, and that's where it's braced when the joints are fully loaded. When the masseters, the temporalis, the medial pterygoids all contract at the same time, the joint is loaded on the medial side of the condylar head. In return, we want to make sure that we appreciate the positioning of this condylar head, and this is what it basically looks like. It's positioned where the lateral side has a lot more freeway and flexibility, whereas the medial side, it's much more acute, and that's where it's designed to handle most of the loading. And so in order to repeat that joint position, we teach a concept called bimanual manipulation. And it's basically taking your thumbs on the chin and taking your fingers and wrapping the two fingers behind the ramus and basically rotating the wrists and seating that joint in the most anterior superior position. I'd like to show you a photograph of a patient on your left where we've established the first point of contact in centric relation. And now that same patient leaves centric relation and goes into their maximum intercuspation. And you can see that there's a significant horizontal slide. And that patient is basically in an end-to-end occlusion. This same patient came to me with an aesthetic concern. They had a bonded Maryland bridge, and basically we loaded the joints, we recorded centric relation, we mounted the models on a semi-adjustable articulator, went through a process of designing a restoration that works with ideal occlusion, and this is the result that we ended up doing. We ended up doing a 3-unit bridge. This patient did not qualify to do an implant, but the point I'm making is that something as simple as this requires some homework. It requires some due diligence to make sure that this patient isn't functioning in an edge-to-edge occlusion. And so when we do our exam, if 3 out of 3 of the systems are stable, then we call that a stable patient. Now, this is something that I don't see very often. It's extremely rare because there's always something happening with our patients, whether it's signs of instability in the teeth, sore muscles, or even a joint problem. But if these patients are stable, we can work in their habitual occlusion because the system is accepting of that. However, if any combination of this system is not working for that patient, then these patients become unstable. And because they're unstable, we have to have diagnostic records. And that basically means either perfect impressions or digital scans, a centric relation bite record, a FACEBO or a digital FACEBO, digital photography or a CBCT, a semi-adjustable articulator is what's required. But I'm going to focus on these three elements for you this evening. And what we're going to do is we're going to talk about manipulation again. Let me go back to that part here. And so let's talk about the photography part. So realistically, here's a photograph of my team demonstrating how we take our diagnostic photographs. And these are the series of photographs that are required in the 21 series photographs. I'll skip through this. I will throw in one extra photo when it's necessary. When it comes to the centric bite record, this is how it's taught in the curriculum. We take an anterior deprogrammer, and if you look on this side, we have a small index or an index of where centric relation is in relation to the joint position. And we record that index, and we close that patient in centric relation into the DLR wax, and then we convert that wax onto mounted models, and it basically looks like this. And so we have mounted models in centric relation in the analog world. I know a lot of you are now doing a lot of digital work, and I think that's terrific. And so you can scan the same arches. You can still take the CR record in the analog way, but we can print the models now, and we can still mount it on a semi-adjustable articulator. And then lastly, if we're going to do it completely digital, then we want to make sure we record centric relation so that we can take a digital bite scan. And so what we're going to do is we're going to use bimanual manipulation, take some bite registration material in the anterior section, load the joints until the first point of contact occurs, allow that material to set, and then we scan our centric bite record with a digital scanner. And so basically, this is what it could look like in the digital world. And you can see the image on your left and the right look extremely similar, but there is a difference between the two. That's maximum intercuspation on your left. That is centric relation on the right. But if you were to look at this from a different perspective, there is a significant difference in where the mandible is positioned in relation to the maxilla. And so it doesn't matter how you do this. You do it full digitally, semi-digital, or fully analog, you need to produce the same results. And that's the most important part. So regardless of the technology you have currently and what you choose to do, you still need to use the proper techniques to get your patient in centric relation, regardless of how you do it. And so that's the point. And so we want to make sure that when we mount our models on the articulator, what we're trying to duplicate is we're trying to duplicate the joint position, which is CR. We're certainly duplicating the plane of occlusion, but the most important part is we're duplicating what we call the arc of closure. And that basically is, let me go back, excuse me. The arc of closure is simply this. It's just how the mandible closes on a circular motion when we start in a stable, repeatable joint position. And why this whole concept matters is because as the mandible closes on this arc, you can see that the distance between the front teeth and the back teeth is significantly different as the mandible closes on the arc. And that would explain why the molars are closer together, because they are close to the joint, and the front teeth have to be a little bit longer because we want to make sure that as that mandible closes on the arc, we want to get all the teeth to touch at the same time. And that's why we have a curve of Spee. And I wanted to just explain that to you all so that you understand why it's important to mount models on an articulator. So let me just review to see if there's any questions or any chats going on. We're gonna basically get to any questions that you have at the very end. But before we go, I want to introduce you to David. And David is a patient who you've already seen his pictures from earlier in the program, but we decided to do composite corrections. And I'm going to explain why we chose this in a few moments. But David came with specific concerns. And one of the things that I've worked really hard is to really listen to my patients and to listen to what is it that's bringing them in, number one, and what are their expectations? And so he broke his dental implant on the right side, but he wants to restore it again. However, he's got sleep apnea. He has history of parafunction. he does not want to invest a lot of money in porcelain. And so my boundaries are very limited for him, but I have to somehow find a way to respect those boundaries. And here's the most important part. He knows his bite needs correction. And so this patient, David, is purely functionally driven. He is not aesthetically driven. However, as you will see, I will have to modify his anterior teeth slightly to improve his function. But I need to make sure I can communicate that with David so that he does not think that I'm pushing aesthetics on him. I'm actually purely relating to his functional desire, but I'm trying to explain to him that we must change your anterior teeth in order to improve your function. So these are the boundaries that I have to work with. I've got to work with somebody who is got sleep apnea. He wears a CPAP at night. He's very compliant. I don't have to worry about him not being compliant, but he does clench his teeth as well. When we go through the clinical exam together, when we palpate his muscles, the lateral pterygoids on the right side are extremely tender, not so much on the left side, and the medial pterygoid is also uncomfortable on both sides. All the other muscles that you see are not uncomfortable, excuse me. When we look at the joints, we want to make sure that we can completely load him, and we can load his joints with full force loading, which is stage 3 loading, and there's no tension or tenderness. So I'm dealing with David with stable joint position. However, he does have a first contact on the left molar, and he does slide into maximum intercuspation towards the right anterior section. As we go through the Doppler auscultation, on the left joint on rotation, it's very quiet. So I'm not concerned about any medial pole issues. However, when he translates, we do have a little bit of crepitus. So I'm thinking there is some lateral pole issues on the left joint. There's a lateral pole click on the left. And then again, on the right side, we're quiet on rotation, but we still have the same result on the right side. So we've got the meniscus slipping off the condylar head or creating some vibration that is allowing us to hear some crepitus sounds on the Doppler. But overall, I can load his joints. Even though he has some crepitus, this is still a very stable joint because on the medial pole, it's very quiet. So we take our photography series. Here are David's initial photos, the full face profile, his full face smile, the retracted full face smile. And I'm going to show you David's occlusal shots. Now, you can see he's had a history of a lot of gold restorations, which is terrific. But there's the implant on the upper right-hand side. So we removed the broken implant crown and we just put a healing cap in, and then we took our diagnostic records and then we mounted those models. And I explained to David that I'm not comfortable replacing the crown until I solve the occlusal problem. Because if I went ahead and replaced that crown right now, not knowing that he had a very unstable occlusion, I'm setting him up for failure, again, on that implant crown. Now, I'm setting myself up not just for failure, but I'm setting myself for owning that problem now. And I don't want to do that. I want David to understand that this is his problem. His malocclusion belongs to him. My goal is to solve it and to correct it. But my goal is not to compromise that in any way that then all of a sudden I inherit a broken implant crown. So there's the occlusal view. Here are the retracted views. You can start to see the signs of instability that are present. These are the 4 photos that I think I really want you to work hard on taking excellent photos on. This is the E-smile picture, and we'll get to these pictures in a moment. This is the tip down smile. This is the horizontal smile, and this is the rest position. And what we're trying to look for here is we're trying to draw an imaginary line on the upper lip and an imaginary line on the lower lip and determining where is that incisal edge in relation to that distance between the 2 marks. And ideally, we want anywhere between 50 to 70%. When David tips his head down and smiles, we want to make sure on a horizontal plane, do the upper anterior teeth fall within the wet-dry line of the lower lip. We confirm that with a horizontal smile picture. And then finally, on the rest position, we want to see in the repose position how much incisal edge is exposing at rest. Ideally, 1 to 3 millimeters is ideal. However, as we age, we will see less incisal edge as we get older, and we start to see more lower incisal edge. So between the top left and bottom left pictures, these pictures go hand in hand, but one will confirm the other if you're not sure as to how long an incisal edge needs to be. Here is David's full series of x-rays that we took before we removed the damaged implant crown. You can see that there's really no pathology present. He does not have high risk of decay. He has good bone support. Periodontally was sound. We did full mouth probings on him, and there was no concerns as far as any perio conditions. But generally speaking, any patient that has signs of instability, we consider that a yellow patient, meaning we have to work in centric relation to create the ideal occlusion for him. If we are not in those areas, then it's either going to be a red joint or a green joint patient. This is called the anterior functioning registration. It's another way of getting the patient into centric relation. It also acts as a Gothic arch tracer. And what you do is you basically spray some material over this, and you seat this over the lower arch, this little pin, and you can actually seat the joint in centric relation. And then you can have David go into excursive movements and protrusive movements. And that kind of gives you an idea of where the condyles are traveling in the protrusive movement and excursive movements. And I did this for a little bit just to see and compare this method versus using the jig. And they both give you the same results, but I just wanted to document that and show that to you. But that's the DLR wax that's present. And that's what that looks like. And so when we look at David's models, I want you to look at his models on the left and right in centric relation. And if you can see, we have space here because we're hitting on a back molar in centric relation. But when David goes into maximum intercuspation, you can see how that space closes up on both sides. And so if I were to restore David in maximum intercuspation, he would be breaking all of the composite restorations within a few hours. However, if I choose to treat him in centric relation, now I've got some room to work with. Now I can redesign the occlusion based on recreating an ideal incisal edge on both the mandibular arch as well as the maxillary arch. That pin photograph that you see is the vertical dimension of the difference between centric relation and maximum intercuspation. And so if you were to take a guess of what that distance might be, you might say 1 to 2 millimeters. For the sake of argument, let's say 2 millimeters. If that is the anterior difference in centric relation, because that pin is in the anterior segment of the articulator, then that means I only have to equilibrate or adjust his occlusion by 1/3 of 2 millimeters to get the rest of the teeth to touch. However, before I do that, I'm going to take advantage of this space to create what I think is the ideal incisal edge position. And so if we go back and look at the study, I've drawn, you can see how thick his incisal edge is here. I've drawn that outline in pencil for you to visually see. And I've done the same thing for David on the upper anterior teeth. But that's where the first point of contacts are, on his left back molars, more so on the second molars. And so I have to contend with this premature contact, but how do I get all the other teeth to touch in centric relation? Because that is the first requirement for the 5 signs of for stability. And so if we continue our analysis of David's occlusion, we can see that when we go into right working, we get a lot of interferences on that same second molar on his left, but we don't have any canine guidance. When we go into the left working, we have even more interference on that back left molar. We're starting to get some working interferences here on the molars, on the bicuspids, excuse me. But what's interesting is we're starting to get some anterior teeth to collide as well. And when we go into protrusive movements, we're not seeing much as far as that, but we're seeing a lot more interferences again on those second molars. And as you start doing more and more of these cases, and you start looking at patients' occlusion, you will come to realize that the second molars are your worst enemies when it comes to this. One of the things I'd like to share with you that I used to have a lot of frustrations with is when I was prepping a second molar for a crown. And I know you know where I'm going with this. You would go ahead and prep that second molar, and then you would confirm that you reduced at least 1.5 millimeters of reduction, maybe even 2 millimeters. And then you would go ahead and make your temporary restoration, and there would be no room to make that temporary restoration. And then you would proceed with the impression, you would make the crown would come back. I'm just speaking on what I used to do. You would cement the crown and you would spend 45 minutes adjusting the occlusion on that second molar. You would obliterate all the anatomy. You would leave that patient with a semi-okay occlusion. And then that patient would come back later and still complain of more issues with their occlusion. That whole process has stopped now because now I take the time to look at what I'm dealing with first before I decide what to do with these second molars, for example. So that's something I've learned the hard way, is that when we look at occlusion first and understand what we need to accomplish, then treating second molars becomes easier and more predictable. I know there was a question that came up. I'm going to wait till the very end, Timothy, and then we will get to your question, I promise. And so there's the first point of contact, and there's the interferences. And so now I've got to contend with this before I even think about making a new crown for him on the upper right-hand side. And so we go through this software called the Smile Wizard, and it allows us to import our photographs. And when we look at the lower anterior teeth, we want to basically draw a horizontal line between the canines and determine what is it that we're going to do with the remaining space that we see between that orange line and the lower anterior teeth. And so if you look carefully on the slide, you can see we need to add height to the lower central incisors as well as the canine teeth. See if composite preps can work after the wax up. The answer is no. Is the incisal plane in harmony? And the answer is no. So we're going to reshape, and I'm going to restore those teeth in composite. And then if we continue with our maxillary incisal edge position, at the rest position, he's not showing anything. But in the E-smile, David is just shy of 50%, which is right about here. So I'm going to add wax on those two central incisors till about 50% for now. Add composite to increase the length and see if that works for the patient. So I'm making notations here as I'm going through this checklist. And so when we confirm the horizontal position, I'm actually okay with the horizontal position because it's not compromising the wet-dry line of the lower lip. Golden proportion, again, I'm going to measure his current width. Again, David is not aesthetically driven. He does not want to close these diastemas. He's perfectly content with the way his teeth look. However, he does want to change his bite. And so I'm going to leave that diastema as it is. And so based on that, I basically measured the right central because I thought that was ideally more normal compared to the other side. And that came out to 7.44. Based on his current golden proportion width, I felt that it was acceptable. That was an acceptable width. And so we weren't going to change that at all. And then that allows me to predictably design the proper length. And that also allows me to determine how much length is acceptable. And so this calculation tells me that all I have to do is add 0.5 millimeter of length to get a more ideal length to width ratio. And so that's what I'm going to do. I'm going to take this information I've learned, and now I'm going to transpose it onto my models. And so I'm going to begin my wax up on my lower anterior teeth. And I always, when I'm teaching treatment planning, I'm always recommending that we start with the canines first. We pick the best canine, we reshape it as much as we can, and then we add wax to create what we think is ideal. We want to make sure that the canine height is slightly above the bicuspid, the first bicuspid, because that basically completes the completion of the curve of Spee. And then I will go to the lateral incisors, and then I will start building my central incisors. And at the end of that whole process, when I get to the laterals and I get to the centrals, I've basically come up with what I think is my best guess as to David's new incisal edge plane. And you can see that plane is higher than the posterior plane, which is what we want, because that increases the chances of us getting posterior disclusion when David goes into those excursive movements. So we've completed step number 4 in choosing the horizontal and vertical incisal edge position. And now we're going to go back to our maxillary anterior teeth. And I'm just going to basically add 0.5 millimeter of wax to just the 2 central incisors for now. And now I'm going to put the models back on the articulator. And what I'm trying to determine is one of 2 things. Are my front teeth going to start touching after finishing the wax up? Or am I still going to have my posterior teeth that are interfering, that were originally there, that are now there? And fortunately for David's case, I still have a lot of room. I still have my posterior interferences here on the back second molars on the left-hand side. And so I have a choice. That pin that we talked about earlier in this evening's presentation, that 2 millimeters of space anteriorly in the vertical dimension of occlusion can be simply changed by just starting to equilibrate the posterior teeth. And so we can either do additive or we can do reductive equilibration. I chose to do reductive equilibration. And so what we're going to do then is we're going to now start equilibrating David. And as I started equilibrating the posterior teeth, the anterior teeth started coming into play. And I'm reshaping those teeth to the point where, as you can see, I'm going to start to get more and more teeth coming into play. And as I keep equilibrating these models in centric relation, I'm starting to see more and more teeth come into play. And once I've established my centric stops, now I'm going to look at my excursive interferences. So I'm going to move the articulator to the left working and right working, and I'm going to make sure that I remove any lines in the back that are preventing canine guidance from occurring. Now, if you look at the pictures on the right-hand side of the screen, you can see I've worked out David's occlusion. I've got canine guidance. I have anterior protrusion. I have no posterior contacts that are interfering in excursive movements. This is my best guess. This is what I predict will work for David as far as improving his function. And so I'd like to share with you what those that work on the models created a treatment plan. And this is something that's, again, fundamentally different in what we're teaching, is that we're training you to create a treatment plan based on the changes you've made on the models. And one simple pearl I'll share with you all is that if you're just changing the incisal edge, you can do that in composite and you can do it in porcelain. If you're changing the incisal and facial side of an anterior tooth, that is a veneer. Whether it's in composite or porcelain, that's up to you. But if we have to change more than two sides, for example, the incisal, lingual, and facial, now that's becoming more of a full coverage restoration. It could be a 3/4 veneer prep. It could be a full coverage veneer prep. If you are going to modify the lingual contours, for example, meaning adding a cingulum, that is a full coverage restoration. So the treatment plan that becomes relevant is based on the work that we do on the model. So with David, we're going to recommend mandibular anterior composites from canine to canine. We're going to recommend anterior composites on the two centrals only. Again, David is not aesthetically driven, and I need those anterior teeth to couple so that we can get disclusion. He has enough canine guidance already, whereas I don't have to do anterior composites on the canines as well. We're going to do full mouth equilibration because we did a full mouth equilibration on the models. When you go through this process, when you start equilibrating your models, that becomes part of your treatment plan. Whatever you do on the models must be transferred into the mouth. And so equilibration becomes even more important. And because I know David parafunctions, I have to make him an appliance to manage that for him, because if he's going to parafunction, he's going to break the composites. And because we're working with a very small budget, compared to a budget that would allow us to do porcelain restorations, we need to manage it to make sure that we have better success. And so I'm going to share with you some slides on the technique of transferring the information that we took from the models. And now we're going to, again, start with the lower anterior teeth. So I'm going to isolate each of those teeth. I'm going to prep the dentin slightly. I'm going to etch and bond. I'm going to take a silicone matrix that I used off of my wax up, and I'm going to compress it to make sure that the composite is in the ideal position. And I'm going to remove and pack any excess. And then I'm going to make sure that we contour everything, and then we light cure it, and we seat another matrix to make sure that we have the ideal shape and form based on the wax up. We light cure it, we separate them, we polish and smooth. We do the same thing for the anterior two teeth. We're going to prep into the dentin. And I will share with you that we're not using any anesthesia here, because when it comes to the equilibration part, I want to make sure my patient can feel the occlusion. These types of preps don't require a lot of preparation, so anesthesia is usually not required. And so we're prepping, we're isolating, we're doing full etch and bond, we're placing composite into the dentinal areas that are exposed. We're contouring things. We are placing our matrix to make sure that the incisal edge position matches what we created on the wax up. We're just finally contouring it with the silicone matrix in place, light curing it. And then now we have composites that are completed, but we haven't completed the full occlusion yet. We haven't dialed in the occlusion. So we're going to basically contour the composites with a fluted burr. We're going to now start working on his occlusion. And when David closes down, you can start to see, we're going to start to see some teeth coming into contact. We start building on that and we begin the occlusion. And this is David basically fully equilibrated with posterior disclusion. We have canine guidance, we have anterior disclusion, we have centric stops on all the teeth. You may not see them clearly on the gold restorations, but they're there. But I've created a stable occlusion for David based on all the work that we did on the models. And so one thing that becomes even more critical when it comes to the anterior guidance is we want to make sure that we harmonize it. And what that simply means is we want to make sure we have nice, smooth disclusion, but we have to make sure we check for a term called long centric. And I'm going to show you what that means. If you look carefully, here's our centric stop, but this red mark that you see here is what we call long centric. And I'd like to explain what that is essentially. When David is in the fully reclined position, I'm loading his joints, getting the occlusion dialed in. However, for not just David, for most of our patients, when they're sitting in the upright position, we might have a slight postural change, which means the arc of closure may slightly be variant, might be different as compared to when the patient's fully reclined. So in order for us to check for long centric, I'm going to have David sit up, lean forward. I'm going to take red articulating paper and I'm just going to have him chew as if he's chewing a piece of gum. If I see any red marks that are away from the centric stop, that is an interference in long centric. What that simply means is, as David, when his mandibular teeth close in that arc of closure, he is colliding right here on his way into the centric stop. And so if we don't understand this, and if we don't correct this, David is going to come back the next day saying, ever since you did these composites, I can only feel my front teeth touch. And so how do I know this? Because this is the mistake I used to make all the time. I used to do anterior porcelain restorations, and I would violate the long centric rule. And these patients would come back week after week complaining of anterior teeth touching all the time. When we remove this line, we recheck it to make sure that there are no more lines like this. And so whether David is reclined back or sitting in the upright position, he's going to close, and those teeth are going to land right back into centric relation. There's going to be no lingual contours on those upper anterior teeth that are preventing those teeth from landing in a safe place. That is one of the most biggest lessons I learned in my career, is to not ignore this simple concept. This got me into trouble many, many times. I just didn't know how to solve it. And so as we finish the occlusion, we start polishing our restorations. I can use discs. I can use all kinds of polishing tools that are available. I'm not promoting any products at this stage. I'm going to leave you to decide on how you polish your composites, but I'm going to bring David back for a follow-up after 2 weeks to make sure that his muscle memory is comfortable with his new occlusion. And again, look at his smile. You can see the incisal edge is 50%, maybe even a little bit longer, but look at his rest position. He's now showing a little bit of more incisal edge, which is perfect for his age. And so I've addressed some of the aesthetics for him, but I've mostly addressed his function. And David, till today, is extremely happy. He's comfortable. We eventually restored his implant in February of 2022. This implant crown was fabricated based on a perfectly equilibrated set of teeth. And now that's the predictability part. How much adjusting do you think I did on this crown? Extremely minimal adjusting, because David had a stable occlusion to begin with. And so this is the concept of predictability, and the marriage of understanding function and aesthetics becomes even more critical. I've basically finished my topic for today, but I want to share with you about some of the programs that are available at the Dawson Academy. Core 1, which is called Occlusion and Smile Design, is basically the introduction course to understanding this philosophy. And for those of you who have not taken any of these classes, this would be the very first one that should be taken for you to start this journey together. For those of you in the United States and Canada, This course is available 3 times this calendar year. We have other classes that are available. We have Airway Symposium. I know a lot of you are probably doing a lot of airway management in your practice, and I think that's terrific. We do have a class in relation to that. I would suggest a study club if you're interested. If you've gone through the curriculum, please find a study club near you. It's wonderful to meet with like-minded people who share the same challenges that we all have. I think that's the best learning experience than any class you could ever take. I encourage you to look at that as well. And then finally, the last class I want to share with you is using clear aligners. And Drew Reingold is an excellent faculty member who teaches this class. And I think if anybody's interested in learning about clear aligners and learning about this concept of complete dentistry, Drew offers a great class with that. So